Hi, everyone. Thank you for joining the Center for Learning Health System Sciences for our monthly Impact seminar. Before we get started, I'd like to cover a few expectations. Today's seminar will be recorded. You can enable closed captioning by hitting the Show Captions button next to the Raise Hand option in the Zoom menu. The public slide deck will also be made available on our website on our Impact seminar page. I will post the link in the chat, along with a short questionnaire asking for seminar topic and speaker suggestions. Following the presentation, we invite you to raise your hand or type questions in the Q&A. In particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder for upcoming LHS events, the next seminar will be on March 3rd with Dr. Erin Tierney. And with that, I'll turn it over to Dr. Genevieve Melton-Mukes to introduce our speaker.
Good morning or good afternoon, everyone. It's my distinct pleasure to welcome you and to introduce today's seminar speaker, Dr. Stephanie Morain. Dr. Morain is a faculty member at the Berman Institute of Bioethics and an associate professor in the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. Her scholarship spans both empirical and normative research. She focuses on questions that arise at the intersection of clinical research, public health, and health policy. Much of her work centers on two key areas. First, the ethical and practical challenges that emerge when research and clinical care are integrated, such as pragmatic trials and comparative effectiveness research. And second, the ethical issues in women's reproductive health. Also of relevant interest is her service, which includes being the co-chair of the Ethics and Regulatory Core for the NIH Pragmatic Trials Collaboratory. She also serves on the executive committee of the Ethics and Regulation Core to the NIA iMpact Collaboratory. She was a former Hike Levi postdoctoral fellow at the Berman Institute. She earned her BA from Lafayette College, where she majored in biology and history, government and law, and her MPH from Columbia University. And then finally her PhD at Harvard's Interfaculty Initiative in Health Policy. Today, she's going to be presenting a talk titled Enabling Ethical Learning, Making Research Ethics Oversight Fit for Purpose. And so with that, please join me in welcoming Dr. Morain.
Hitting the wrong buttons already. All right, well, thank you so much for that very kind welcome. As a native Iowan, I'm actually always sad when I love doing these virtually. It makes life easy, but Minnesota is actually a place I would happily return, acknowledging the challenges now. So thank you for making time for this. I cannot pretend that this is the most important thing that's going to be top of mind for you all, but it's an area of interest and one that I think is really important for our healthcare system. So appreciate your time and very much looking forward to engagement because I think these issues are really hard. My colleagues and I have proposed one approach. I certainly won't pretend that we have figured it all out. And there are a lot of kind of devil in the details considerations for which I'd very much welcome your feedback and insights. So with that, I have some, we'll share my slides, acknowledging this is never as seamless as it feels like it should be, but we'll see how many clicks it takes me to get there. All right. Looking good? Okay, thank you. So it said the title of this is Making Research Ethics Oversight Fit for Purpose. And I should acknowledge this reflects a lot of shared work with collaborators, particularly Nancy Cass and Ruth Faden. So for this work, I want to start up by noting that we have kind of 5 background assumptions that are motivating our work in this space. The first is that patients, doctors, and other decision makers tend to lack rigorous evidence for many clinical decisions, and often many clinical decisions that are either very common or have tremendous impact or significance for patients, families, and other decision makers. The second is that embedded in comparative effectiveness studies are often well suited to address these evidence gaps, and here we're specifically focused on comparative effectiveness studies of treatments that are widely used within the healthcare system, so comparing existing therapies rather than examining, first in human or otherwise unapproved therapies or treatments. Third, Some comparative effectiveness studies don't get done or get done using weaker or less robust methods or are substantially delayed in their conduct. And one reason for this is that the burdens associated with or the biases resulting from fulfilling the general obligation to obtain traditional informed consent for research. And here, when we're saying general obligation, often the regulatory requirements associated with obtaining informed consent, but recognize that these are undergirded by ethical considerations and important ones. And so the fifth assumption is that because we don't have many comparative effectiveness studies are not done or are done with weaker or less robust methods, we don't have the evidence to guide clinical decisions, and patients may therefore continue to receive suboptimal clinical care. So our challenge is assessing when requirements for informed consent may permissibly be waived or altered for studies that are comparing treatments that are widely used in clinical care. And so this presentation builds upon work that we published in JAMA now almost a year and a half ago. And so I'm flagging that article here for reference, as well as an accompanying editorial from Holly Fernandez-Lynch and Jan Kramer. And so our proposal is that ethics oversight for clinical research must be fit for purpose. And here our argument is that clinical research is not all the same, and the existing system does fit some studies. So if we think about the existing regulatory apparatus and IRBs and related requirements are generally appropriate if we're thinking about early phase clinical trials, first in human, phase 1, phase 2 research, particularly when we're thinking about drugs, devices or biologics for which we don't have a robust evidence base that are not yet approved. However, our argument is that this one-size-fits-all approach is problematic, especially when we're talking about CER, comparative effectiveness research studies, or pragmatic clinical trials. And so the concern is that our existing regulatory apparatus was really designed for brand new therapies for which we did not have a strong evidence base. And it's predicated on this expectation that clinical research is where there's greater risks and uncertainty, and therefore we need to have a heightened level of scrutiny as compared to clinical care, where the belief is that risks that are lower involves lower burdens. And we don't think that that assumption holds if we think about particularly areas where there's substantial variability in ongoing kind of everyday clinical practice. And our concern is that the excessive oversight for these kind of CER and PCT trials results in greater than appropriate burdens for researchers and for collaborating clinicians that hinders the conduct of valuable research and may mislead patients about how risky research participation is for these types of trials. And so we'd propose that oversight should be based on the ethically relevant features of a specific project and not first on whether an activity is labeled as a clinical trial versus quality improvement or implementation science or another term. So the ethically relevant features that we propose are relevant for assessing when waivers or alterations of consent might be appropriate, but also kind of the level of scrutiny more generally with which we should apply to comparative effectiveness research are these two features. The first is the impact of that trial on welfare, so the extent to which research participation increases risks and burdens as compared to usual care. And the second is the impact of that research activity on autonomy, so the extent to which research restricts meaningful patient decisions about welfare and about their care. So first, looking at the impact on welfare. So this is where we would traditionally assess considerations for risk and burden. And we'd propose that the current minimal risk definition focuses on absolute risk or is at least ambiguous. And this can inflate the perceived risk of research participation, especially in high-stakes clinical contexts and or including for comparative effectiveness research. And we propose that oversight bodies should consider how much additional or marginal risk and burden is introduced with participation compared to that of usual or recommended care. And here, try to make this more granular, we propose an incremental risk standard. And so under the incremental risk perspective, if we're comparing two or more standard of care interventions, the risk level determination should be made based upon the marginal or additional burdens of research participation relative to those of ordinary clinical care. So if we are comparing, for example, one of the case studies we'll use later, if we're comparing video versus direct laryngoscopy, our argument would be if those treatments are widely used in clinical care and there's variation even among very good healthcare systems or within healthcare systems about which one is most appropriate, it is appropriate to randomize between those two approaches. And the risks involved in the research would only be those related to anything that's being done additional as part of the research, so additional related to the data collection. And we wouldn't consider the risks of the underlying treatments being compared to be risks of research. Importantly, this is not the perspective that the OHRP set forward in 2014. This is only draft guidance, but it certainly has continued to have influence to a varying degree depending on the healthcare institution. What OHRP proposed in its draft guidance, and this was following the controversial support study, which several of you may be familiar, OHRP, so the Office of Human Research Protection, stated that the reasonably foreseeable risks of research in a study include the already identifiable risks of the standards of care being evaluated as a purpose of the research when the risks being evaluated are different from the risks some of the subjects would be exposed to outside the study. And in 2024, at a meeting with which OHRP attendees were participating down at NIH, they were delivering this consistent message. So they argued that if the research changes the treatment that a person would have received if they were not in the research, then the treatment is a research intervention and its risks need to be considered. This is the case even if the study involves assigning people to one or more versions of usual or standard care. So under OHRP's view, if you are comparing two treatments with which reasonable doctors might disagree as to which is better, randomization then makes what otherwise would be a clinical risk becomes a research risk. And we can see how, given the criteria for waivers or alterations of consent, under this perspective, it would be very hard to waive or alter informed consent for many clinical interventions because very few of them would then be able to meet the minimal risk standard. And that may, or may not be problematic depending on your view. I think as someone who believes that we have insufficient amount of comparative effectiveness research going on, that interpretation is concerning to me because I think it chills very socially valuable research. So would love to have a conversation on that when we get to the Q&A, but I want to move just to continue to kind of map the territory for us to the second criteria, which we argue is ethically relevant when we're assessing the appropriateness of waivers or alterations of informed consent. And that's the impact of participation on whether meaningful patient decisions. And so this is really grounded in the ethics principle of respect for autonomy. And respect for autonomy requires considering which decisions are meaningful for patients. And we propose that there are two components of whether a decision is meaningful for patients. First, is this usually a patient decision? Is patient input ordinarily sought, or should it be? And second, is it a meaningful choice or decision for patients? Does the research limit or remove from patients a decision about which they might likely have important preferences based on values, logistics, or other priorities? And one of kind of the most stylistic examples I'll give that I think is illustrative is if we're thinking about, comparing PT versus surgery for low back pain. Even if we think that there is, insufficient evidence in the field as to which is superior, it would be ethically problematic to randomize patients without informed consent between PT versus surgery because that's very clearly the type of intervention for which patients are likely to have preferences based upon their values, logistics, and other priorities. And it's certainly the type of decision with which patients would normally be involved in the clinical care contexts. So as I mentioned, kind of the rationale for this second ethical consideration is grounded in respect for autonomy. And so this consideration of whether the decision is meaningful for a patient derives from the general obligation to respect the autonomy of others. But importantly, the obligation to respect autonomy does not imply unfettered choice in every aspect of people's lives, nor that all choices are equally worthy of respect. And here I just want, an example I give for my students when we're thinking in the context of public health ethics, we think very differently about different types of choices individuals make. And correspondingly, we think differently about how problematic it is to impede an individual's ability to make that choice. So in the context of public health, we think very differently about, for example, a regulation that would attempt to limit how much sodium is in processed food than, for example, regulations that restrict whether, when, or how many children a woman might end up choosing to have. Those are very different types of restrictions on an individual's ability to kind of chart their own life course and design their life in a way that reflects their own values and priorities. So respect for autonomy, like other ethics commitments, is important, but it's not absolute. The obligation to respect autonomy is bounded by other morally important duties, including promoting welfare and seeking justice. In the clinical context, it's also bounded by trade-offs where people have other interests. So institutions need to function efficiently for large populations of individuals who cannot reasonably and realistically be personally consulted on every practice or policy. Many, if not most, operational decisions are neither disclosed to patients nor discussed with them, and they're certainly not decided by them. So, most classic example perhaps is if we're thinking about kind of which type of hand sanitizer is used within a healthcare system, which type of antiseptic solution is used as prep before surgery. These are not decisions in which patients are typically engaged, and we would argue then that's a rationale for by which it might be permissible to engage in comparative effectiveness research for those types of interventions without engaging in prospective conversation and informed consent with patients, because those are not the types of decisions in which patients would otherwise be consulted outside the research context. Nor are they decisions for which patients are likely to have meaningful preferences. And so this rationale builds on more foundational work on autonomy and liberty. So liberty is an intrinsic interest, but it's also instrumental in allowing us to pursue life choices we value. While we often treat autonomy or liberty as monolithic concepts, not all liberties are morally equivalent. And this goes back to my earlier example of it's a different type of liberty to decide, how much sodium is in the chip or the cookie that you want to eat versus, the type of religion you get to practice or whether, when, or how to have a child. Not all liberties deserve or require equal protection, and assessing the importance of the liberty interest requires determining which are importantly relevant to welfare interests and which are importantly relevant to other parts of self-determination that we value and care about. So connecting the dots back to research ethics, we need an approach that can recognize and distinguish which liberty claims have deeper versus less important moral significance, which require protection or consent to restrict, and which do not. So just for those who are interested, I think great background reading at considering liberty in the context of public health ethics, but has implications also for the research ethics context, is this work by my colleague Ruth Faden and her colleagues Madison Powers and Yashar Sagai. So bringing this together, what would fit for purpose oversight require? It would mean that randomized trials, particularly comparative effectiveness trials, would require a case-by-case evaluation. A trial comparing different nurse staffing ratios is the type of trial, it's the type of decision in which patients are not usually involved, despite the fact that there might be a welfare impact. So part of the reason that we would test nurse staffing ratios is because we expect it might have meaningful differences for patient outcomes. But these are the types of decisions with which patients are not typically, and we would argue, appropriately consulted. And that would be a reason why it might be appropriate to conduct these trials without prospective informed consent if obtaining consent would be impracticable. If we look at the consideration of surgery versus physical therapy, as I referenced previously, these are the types of clinical decisions for which significant patient involvement is important because there's likely important preference sensitivity. And this would be a case where randomization to a trial without prospective informed consent would be inappropriate. But if we think about something like comparing different types of statins, that's a type of choice that may be less preference sensitive and therefore might be more appropriate to conduct under a waiver or alteration of consent. So to help concretize thinking here, and this is where these case studies in our discussion would love to use those or others as a jumping off point for us to reflect on the extent to which this framework is or is not helpful. And if it is not helpful, that's also helpful for us to hear as we move forward. But to help concretize kind of what the implications of these this guidance would be, I want to propose a couple case studies for our joint reflection. So for these cases, I'd like to propose that we assume the study is randomizing between widely used and/or approved therapies. The investigators have presented sufficient evidence of clinical equipoise, so we have no a priori reason to believe that either or any of the interventions to which individuals will be randomized is superior to another, or that there is another therapy kind of out in the world that would be better. And physicians have discretion to override the assigned treatment when appropriate. So if a patient has a contraindication to the assigned treatment, for example, a physician would be able to say, no, my patient's not going to participate in this study. I'm just going to choose the treatment to which they'll be assigned as I normally would in clinical care. So classic example there, if we're randomized between two antibiotics and the patient has a contraindication to one of the antibiotics, the physician would have the discretion to use the appropriate medication for that patient. Okay, so for our first case study, comparing antiseptic skin solutions to prevent surgical site infection. So the compared interventions would be two widely used antiseptic skin solutions containing alcohol. The risks here, local side effects from either solution are estimated to affect 1 to 3% of patients and include skin irritation or redness and rash. These effects are usually mild and resolve quickly. The study design and sampling frame, cluster randomized trial conducted within 20 hospitals for all adult patients requiring surgery to repair a fractured limb. And the study outcomes are surgical site infections, unplanned reoperations due to infection. And I'm using this adapted from the PREP-IT trial, which was published in New England Journal of Medicine. And so if we take the framework and apply it to this case, how would we consider the impact on welfare? And here's the assessment of risks and burdens. Well, the local side effects here, one, we argue would be fairly minimal, but also there's no incremental risk associated with the research beyond that related to data collection. So if we assume that there are appropriate privacy and confidentiality considerations in place, participating in this research does not present any additional physical risks to any individual beyond that which they might be experiencing in regular clinical care. And with respect to the welfare consideration, decision about which antiseptic skin solution is used before surgery is not the type of decision in which patients are normally consulted or routinely involved, nor is it the type of decision with which we would expect patients to have meaningful preferences. So both of those would weight towards it being appropriate to waive or alter informed consent, particularly in circumstances where it may not be practical to obtain informed consent. If we look at our second case study, so here we're thinking about a more high stakes intervention. So comparing laryngoscopes for emergency intubation. So this would be video versus direct laryngoscopy for emergency intubation. And this is adapted from the device trial, which was also published in the New England Journal of Medicine in recent years. So the risks here of either procedure include airway trauma, wrong tracheal tube intubation in esophagus, vomiting and aspiration. The study design and sampling frame, it's individually randomized trial conducted within 17 emergency departments and ICUs for all adult patients requiring emergency intubation. The study outcomes are successful intubation on the first attempt and occurrence of severe complications during intubation. And so here I think we can really see the differences in our proposed view of incremental risk as how we should assess the risks involved in a trial versus that of OHRP. So our perspective would be consistent with the argument that was set forward by the trial principal investigators at Vanderbilt. And their argument was that critically ill patients undergoing tracheal intubation in the emergency department or at the ICU are at significant risk for morbidity and mortality from their underlying illness. Most patients undergoing tracheal intubation in routine care are intubated using either video or direct laryngoscope on the first attempt. Any benefits or risks of these two approaches are experienced by patients undergoing tracheal intubation in clinical care outside the context of the research. So, as a requirement for enrollment in this trial, the patient's treating clinician must believe that either approach would be a safe and reasonable approach for the patient. If not, the patient would be excluded. Therefore, making the decision between the two approaches randomly, rather than by a clinician who thinks either approach is safe and reasonable, is expected to pose no more than minimal additional risk. And so here, this is consistent with the incremental risk perspective, and therefore, this trial might permissibly proceed under a waiver or alteration of informed consent. However, OHRP's perspective would be, if we go back to the risks of the risks involved in either clinical procedure, OHRP's draft guidance, which has not been finalized, importantly, would argue that if you are randomizing, then the risk of wrong tracheal intubation, for example, was a clinical risk, but if you are randomizing, it becomes a research risk. And then these types of studies could never be conducted under a waiver or alteration of informed consent, which means these studies often could not be conducted at all. Our third case study is comparing different influenza vaccines. And so this is adapted from, provided the clinical trial registration number here, another trial published in New England Journal of Medicine out of one of the Kaiser Health systems, comparing recombinant versus standard dose influenza vaccines. The risks of either vaccine are local injection site pain, headache, fatigue, and muscle aches. Study design is a cluster randomized trial within the integrated health delivery system of over 1 million patients aged 18 to 64. Study outcomes are influenza-related hospitalizations, and community-acquired pneumonia. And if we think about here, we're going to take the incremental risk perspective. If patients might receive either recombinant or standard dose influenza vaccines in usual clinical care, that either would be appropriate for a physician to provide to them, and there's no good evidence prior to the trial to suggest that one is superior to the other. And importantly, would also require the expectation that patients aren't typically consulted about which dose to have, and would not have a meaningful preference between them. And this is where, would certainly invite discussion, particularly from either infectious disease or primary care, as to whether or not this is consistent with how usual care is practiced, and or how, it should be. Are patients likely to have a meaningful preference? We can see how there be a strong argument again why it would be appropriate to conduct this trial under a waiver or alteration of informed consent if the alternative would be that the trial couldn't otherwise be conducted. Case study 4 is comparing different analgesics for pain control. Compared interventions are narcotic versus non-narcotic analgesic for pain control following open fracture, or for open fracture following acute trauma. So the non-narcotic has a 10% rate of GI distress. The narcotic has a 20% rate of drowsiness and a 15% rate of nausea. Both involve similar rates of constipation. Study design would be individually randomized within 20 hospitals for all adult patients requiring surgery to repair a fractured limb. The overall pain score would be 30 minutes after administration. And here is where might suggest that we might be more skeptical about a proposal to waive or alter informed consent, because patients are likely to have a meaningful preference between a narcotic versus a non-narcotic drug. And this is a decision about which patients usually or appropriately should be consulted, given the different risks involved and people's likelihood to have meaningful preferences about those risks. And the fifth one is one, we're all motivated by the things that affect us on a day-to-day basis. I found interesting. It's again adapted from a real-world trial out of the Kaiser system, and it's comparing interventions of a 1 versus 2-step screening for gestational diabetes. The 1-step screening is a single 2-hour visit fasted. The alternative is a non-fasted 1-hour visit, but then a 3-hour fasted test for 1/5 of patients. The risks here, at least the immediate risks, are minor physical harm from blood draw. Study design and sampling frame would be all pregnant women who've received care in 2 healthcare systems. Study outcomes are gestational diabetes, hypertension, or preeclampsia, primary cesarean section, and perinatal composite outcome involving stillbirth, neonatal death, shoulder dystocia, and bone fracture. And here, this is the type of decision with which My expectation is that patients are not routinely consulted or involved in that decision. At least I, as you know, a formerly pregnant individual, did have a meaningful preference, but it's not something with which I was involved. I cannot pretend to say that I'm the typical patient, but I came back to Hopkins, quite pregnant, had maybe 3 months before I went on maternity leave, and was very desperate to prove to them that I was a worthwhile hire and was not going to be dead weight. So I am frantically, at the hospital during every OB visit, with my laptop trying to crank out as many possible papers as I can. And the implication for my life and for travel time is very different for one step versus two. Is that the type of decision with which patients should be consulted? Or this type of case and a couple others, I think push upon our intuitions are about whether or not there might be some operational decisions that are appropriate that patients are not consulted, but when we move it to the context of research, perhaps we might think differently. And another case, which I would very much welcome thoughts of the group, is when we're randomizing between two different lengths of dialysis session. And so there was a large-scale pragmatic clinical trial led by Laura Dumber out of Penn, where they were randomizing patients at the cluster level within dialysis clinics to usual dialysis sessions, which would be about 3.5 to 3.25 hours versus about 4.25. And here, presumably dialysis sessions are not the length of sessions or something that are set by the dialysis clinics themselves. Patients are not routinely consulted. We don't have variation within, among patients as to how long they get their dialysis session. This is an operational decision. And I'm sympathetic to critiques that we might think differently about that decision if patients are being asked to stay in the chair 45 minutes longer to answer a research question as opposed to a decision based on what the clinic anticipates is going to be best for patients or another kind of motivation that might be shaping that decision making. So this is where my intuitions are not as clear and would very much appreciate additional thoughts about whether there are some types of cases for which it might be appropriate that patients aren't involved in a clinical or operational decision, but when we move it to the context of research, there might be other values and preferences of patients that weight more when the decision is being made for the purpose of generating socially valuable knowledge, rather than an expectation that it's better for the patient and or for the health system. And so just for reference, here's the table from our JAMA paper, and I've also presented for reference for those of you who don't live in this world, are 5 requirements from the federal regulations for waivers or alterations of informed consent. So Genevieve, I think I will pass back to you and would very much love thoughts, questions, critiques, concerns, because this is very much an ongoing area of work and would love you all to help me figure out where we went awry.
Dr. Morain, thanks so much. So we're going to open it up for questions now. Please do put them in the chat. And I will go ahead and start with an initial question. I'm very curious, thinking about University of Minnesota and their IRB approaches that you've seen nationally, maybe across institutions, having that lens already, of how to have these discussions. And I love the case studies because it really brought it to life. We do work with our IRB and do a bunch of pragmatic interventions, and the discussions we have found to be quite variable. So
this is probably a longer conversation. I think my first takeaway is if your impressions are that things are quite variable, I think that's very true both across IRBs, also interestingly within IRBs. And the latter, some of my colleagues, I will say that, the trial of comparing different, the video versus direct laryngoscope, believe there was then an interest in doing a follow-up trial potentially on, comparing different types of video laryngoscopes, where the IRB then said, well, that's going to present more than minimal risk. It was like, but you just let us do another type of trial under this termination so we can also see kind of as people rotate off the IRB, different views in that risk perspective. I think we can think about that variability in multiple ways. I mean, for some types of IRB decisions, heterogeneity might genuinely reflect differences in, the patient population or other contextual features, and we want to preserve that level of kind of local context. I'm pretty skeptical that that's what's happening for when we see differences in decision making for these types of trials. I find it implausible that patients in one healthcare system truly have a different view about their rights and welfare, for example, and how we should interpret rights and welfare in the context of waivers or alterations of informed consent. I think one of the drivers we are seeing is, this is certainly not the only, but I think one is how much people believe that OHRP guidance is determinative or influential, and how much people, for a variety of reasons, have been willing to discard it. In conversation with some IRB leadership, I think there have been some that have said, it's draft guidance, it was never finalized. We really don't have to pay any attention to it at all. I think there are others that are far more risk averse. And I think, there are other factors, whether or not we think there are good ethical reasons to view them differently. If you're doing a trial in the context of neonates, people might be more risk averse after the support study. We had colleagues say, we are likely to think differently about it. Is there good moral reason for doing so? No, but after that controversy, people are just pretty gun shy about going back into that space and being, accused by Public Citizen and others of unethically researching on babies. That was yes, I think there's heterogeneity. I don't know if then there's probably a separate conversation about what can we do to reduce that heterogeneity. I don't think there are a lot of concerns I would have about the lack of predictability. So if you haven't, talked to a couple investigators who have spent 6 to 9 months with the expectation that their IRB takes one view, submits something to them, and the IRB rejects it. And so you have some of those investigators who just then are disinterested in proposing more comparative effectiveness research. I think nothing about that is good for the field. It's entirely wasted effort, both for that short term, but then also, we've lost an investigator who was otherwise committed to this space. I also acknowledge I have a pretty strong view, and maybe towards the tail of the end of the distribution, about how much we should be prioritizing this type of research. So I'm sure those who have a different view about the permissibility of waivers and alterations might approach these conversations differently.
All right. Looks like next we have a question from Matt in the Q&A that says, in situations where treatment A and B are viewed by the average clinician with, I always forget how to pronounce this word, equipoise, but what role do you see for casual inference from observation data, given that the treatments are assumed to be assigned as if by random?
Yeah. Matt, are you able to get off mute now to kind of talk through your thoughts on this?
If you raise your hand, Matt, I can take you off mute.
Cool. Am I unmuted now?
Yeah.
We can hear you. Thanks.
Fantastic. Yeah, I was just curious, like the scoping one, if doctors are already sort of view it with equipoise, and that I would imagine then they're sort of randomly assigning patients, or different doctors are making one choice or the other. Yeah, just like what role does the ability to use causal inference have in assessing the risks and need for a trial?
Yeah. So if in some sense, is this a kind of statistical question of, do we actually need, randomized trials, or are there places where we can be looking at observational data and instead get a pretty good idea of what's going on? Is that the nature of the question?
Yeah, I guess so. Yeah.
Yeah. So I will readily defer to, the biostats colleagues and others. I think there are good reason why we still need randomized trials. One is because I think one of the most important is, I don't think that we can take equipoise and view that as then implying that variation is, distributed in a way such that it parallels random assignment. And so just as one example for I think, so it's important to look, I think where observational data can be really, really important is to start to understand the nature of the variation. And this is where I think, again, you're going to have different ethics people think differently. And my intuitions here are not super clear. And this is where I would love more thoughts. But, do we think differently about, if we see variation, does it matter that that variation is within or across institutions? So the video versus direct laryngoscopy trial, if I recall, I think that, was it, I don't know. Well, stylistically, we'll say it was 50-50, but the 50-50 was because the ED did it one way and the ICU did it another. I think that was actually the case for etomidate versus ketamine, but same example. Do we think differently about it when it's, within unit, when it's across units, or when it's across healthcare systems? Anecdotally, I have colleagues who say their IRB feels more comfortable making the argument for randomization if it's within their healthcare system rather than across healthcare systems. I can see why we can make the argument that, a patient's care is likely to be, equivalent within the trial versus outside the trial if, they happen to either, if they came to the healthcare system and they got Dr. A versus they came to the healthcare system and within our healthcare system it randomized you to treatment A. I think that is where, getting to your point, I think some of the value observational data is to help us understand where the variation is and to think about whether that variation, both, what's the statistical importance of that, but also what moral relevance is there in thinking about where the variation is and how that should shape whether or not we think having a patient enter a trial changes their care in a way that is morally relevant. But short takeaway is, I've been convinced by my biostats colleagues that there's still very good reason to be doing randomized trials. And I think a lot of the data from many of these trials supports the fact that, the fact that there is equipoise certainly does not mean that decisions are randomly distributed.
I guess if I can ask
Yeah,
one
please.
follow-up then. I think from the patient perspective, oftentimes in things that I've read, patients believe that they have a doctor that they really trust and they like what they have that relationship and they want to believe that their doctor might not be the average, that they're going to pick something better than the rest of the doctors would. And that gets to the variation not being equally distributed. So I'm curious about if you've had an opportunity to bring in that patient perspective or talk to patients about how they feel about how this risk is distributed and when there should or should not be informed consent.
Yeah, so I think this is a really important question. I think there are a couple layers there. One is the empirical question of kind of what do patients think, how supportive are they, and do patients believe that randomization is morally relevant insofar as morally relevant and morally relevant insofar as it shapes risk. Doing empirical work in this space is really hard for a lot of reasons, one of which is you'll get patients on board with okay, we need to do this type of research, but my doctor knows what's best. And getting over that hump of actually your doctor might not is really, really hard. Or this expectation of you can randomize, but my doctor's going to pick the drug for me because my doctor really knows based upon, particular features of me, etc. So empirically, this gets hard because I think there's a lack of buy-in among patients, and for good reason, because we want patients to trust and like their doctors for doing this type of research. There's also a question about, what's the appropriate expectation of a patient and when, so we back up to, the regulatory criteria for waivers or alterations of consent under the federal regulations. One of them relates to this question of, the the waiver or alteration will not adversely affect the rights and the welfare of the subjects. This is a space where either there's a lot of hand waving, or I think IRBs have generally been silent. And I think the decision about waivers or alterations tends to be driven by practicability of consent and minimal risk. I don't think there's been a lot of thought about the rights and welfare piece. We are proposing it's this meaningful patient decision, but wrapped up in that is, also an assumption that you have a right to a certain type of care. You might not have a right to the care of your doctor always gets to pick the medicine you want that, he or she thinks it's best, if we don't think that decision is meaningfully grounded in a certain type of evidence. And that I acknowledge is hard at deciding, when do we want to give discretion to physicians, even if there are not, a perfect number of comparative effectiveness research trials to justify why they're picking one versus the other. Like when is it appropriate for, researchers and health systems to override physician preferences that are not grounded in robust data of a certain form, I think is hard. So I don't have a great takeaway for you other than that's hard. I'm inclined to say that there are some types of decisions for physicians that we know aren't based upon robust data and are very much shaped by practice patterns where you trained, which drug rep was able to get into the healthcare system before we started tamping down on that more, that I don't think deserve a great deal of more weight, but how we disentangle which types of preferences do and don't is where I think a lot of that kind of hard work has to be done at the level of individual cases.
Yeah, thanks for wading into that murky area. I appreciate it.
Muddling might be muddling through the murky area.
All right. It looks like Molly has her hand up. Molly should be able to talk now.
Okay, thank you. Hi, Stephanie. My question is a little bit more about the practical framework of working with the IRB. So a team of us, both here in class and a couple from the School of Public Health, we did a literature review project recently that hoping to get published soon. Looking more at the broader IRB review process and approval process for these types of sort of gray area projects like quality improvement, learning health system, comparative effectiveness of already standard of care. In your research and in your experience, have you found good examples of frameworks that have been developed to support that variability? Like the example I have is that I attended a conference not too long ago, much smaller university, but they had one person who reviewed everything that came in that might fall into this sort of gray area and then triage to a particular committee or full IRB review. Have you found anything similar or, good examples that we could look at to learn from?
My first take is I'm so excited to read that paper. So at whatever stage you are willing to share, I would be delighted. I think I might want to separate between kind of how systems make the initial determination of does this even get routed through the IRB system versus if we determine this is research, at what level of oversight's appropriate, and do we think this is something that requires that for which in waiver or alteration of informed consent would be appropriate. I think there's been a fair amount of literature, and a lot of that I think was more 10 to 15 years ago about how systems are dealing with the quality improvement versus research divide. I admit I am not as super up to date on that literature, other than seeing a very recent paper from colleagues saying, we're still not doing a great job at being systematized at how we do this, and there's a lot of heterogeneity across healthcare systems.
Right.
With respect to kind of the question about once it's a research study, when and in what circumstances might be waivers or alterations be appropriate, what I have seen be really influential ends up being, I think there are a couple of health systems that have become more comfortable making these decisions, and I think have developed a facility in talking to IRBs and talking across systems about making that justification. And this is where I think we've actually seen influence of the single IRB system, is that you have, a couple institutions have been willing to say this is appropriate and here's why, and have kind of had conversations at the head of the IRB level between institutions to develop level of comfort there that have started to get some buy-in. maybe have the snowball rolling down the hill. What I would love to see is some sort of decision tool that can help walk through the decisions for an individual trial. That's something actually immediately after this, working on with some colleagues, because I have seen, a couple individuals basically kind of make the informal rounds and, individual who's the head of IRB from program X gets a call from program Y. They're able to kind of talk through, adjudicate, and that's not it can be a great system when if you know the person to call who can help you think through this. That's not exactly a transparent system, nor is it one that's particularly easy to scale because there are only so many of these individuals. The extent to which we can be developing kind of those frameworks and other toolkits to support these decisions, I would love to see. We are making steps towards that end, and this is where, in future years, we're happy to circulate, and you guys can tell us the extent to which it's actually helpful for you. But selfishly, I would love to see the work that you've been doing to this end.
Yeah, absolutely. We can, happy to share the manuscript. I can send it after the call.
Love that. Thank you.
Yeah, thank you.
All right. Well, thank you again to Dr. Stephanie Morain for taking the time to give this talk, and thank you all for attending. Again, in closing, please join us for our next seminar on March 3rd at noon Central Time. This concludes our presentation. We'll see you next time.
Thank you all.